We are live now. Shruti ma'am, Usha Kini ma'am, kindly start your webcam. And
yeah.
You may start after 1 minute, ma'am. The audience will be joining in now. Go ahead.
Yeah, just sit here. You can.
Hello everyone and welcome to another virtual slide seminar by KCIAPM. I'm Dr. Shruti Prasad, Associate Professor of Pathology, KIMS Bengaluru, and also member of Social Media Committee KCIAPM. At the outset, I would like to thank everyone for joining in, and I would request you all to share the link with your friends and colleagues so that everyone can benefit from this slide seminar. On behalf of KCIAPM, I would like to thank Morphel for digitizing the slides for all of its viewers. Today's slide seminar is titled Glitters But Not Gold. And this slide seminar is going to be conducted by Dr. Usha Kini Madam, Professor Research, St. John's Medical Institute. We have 6 cases for today's slide seminar, and all of these cases are going to be presented by 6 postgraduates across the state. Now, before I hand over the platform to Usha Kini Madam, just a couple of housekeeping notes. Please set your screen size resolution at 720 pixels to maximize viewing. And any questions can be put up in the chat box, and we will take up the questions at the end of each case. I would like to hand over the platform to Usha Kini Madam now.
Very good morning, good afternoon to all of you. It's indeed a very pleasant moment for me to conduct this virtual online seminar with 6 slides, keeping in mind that we have our first year postgraduates who are just probably 1 month old. So with this, I have taken the very basic slides, and this session is going to emphasize what is one need to look at morphology and how to word the report and communicate to the clinician. So to keep, to stress with the better words, it's that we are pathologists. We have received a biopsy or the tissue, whatever that could be, from the patient with the clinician on the other hand. So we are in between and we have to form the link. It is not that the clinician sends the biopsy, we report, and there it stops. There is something that goes from us, just not the diagnosis so-called, but also something what next to be done for the patient, if that could be done from our end. With this small note, I'd just like to share a few slides of mine which would emphasize what exactly is it wanted from the pathologist. The future of pathologists lies in they're looking at who will be writing your prescriptions in the future. We should always remember that we decided to become pathologists only after we finished our course, and that means to say we are basic physicians. So we know how to examine patients, how to gather data, and now we look at something that comes out of that lesion from that patient to take it forward for a diagnosis. So with this, there is this article which is very inspiring, and I think one should read this in the journal of RCPA.
Ma'am, sorry to interrupt. Your screen is not shared.
Okay, sorry. Is this okay now?
Yes, ma'am.
Yeah, okay. So the spice of life, as we look at it, is the precision of medicine, and it holds a great promise for all of us. And if we don't improvise or improve our diversity in all the areas on this field of histopathology, let that be major or minority groups, I'm sure we are going to be left behind. So we need to keep pace. We need to move from where we are sitting at the microscope towards the patient. And I suppose that can only be done when we start behaving like physicians, examine the patient to the extent that is possible, and correlate with what we have. And we are like a jigsaw puzzle. And if this puzzle of ours is missing, and I'm sure the link is going to be broken. So we play a very important role as a pathologist in the patient management. So we must grow beyond being just a pathologist. We may feel great when we make a diagnosis, but just not that. There is a lot more that can be done. And if you look at it in the scenario of the clinical findings, the image findings and the treatment that the patient has undergone and what may not have been picked up by the clinician, I'm sure you will be adding to that, and that would be wonderful. So I have just devised a few laws, or, I say this must be followed. First is to say I'm first a physician. I seek to protect and improve the health, the well-being and social standing of the patient. So we have a onus, we have a responsibility, and let's take that responsibility in the management of his disease. The second law is I am to apply the art and science of pathology to make an accurate, timely diagnosis. It is accurate and it is timely. So it is not that we keep, looking at a slide and take time to report. No, yes, we could, yes, but there must be something that's happening in between, informing the clinician, how far have you reached, what more is needed. I know the work in the lab takes time, but we are supposed to maintain a certain time and to operate my lab according to the sound scientific principles and the ethics of and abide by the first law. Okay. And the third law is behind every slide there is a patient. No, it's not that I'm going to see slides, but you're going to see patients. So that's the beauty of pathology. And every slide, the tissue has come from a patient. And the patient is eagerly waiting to see what you have diagnosed and the clinician to take it forward from that particular moment. So what information would you include in a report? This I thought is very important and it is mandatory. And especially for the first years, you all wonder what is that little piece of A4 size report, a pathology report that is issued to the patient. Yes, we should have the identifying information of the patient, starting from name, age, etc. All that is needed. When is the sample received? When is the report going? Who is the clinician? From where is the sample come from? Is it a biopsy or a slide review or is a block review? But all that you can generate only and only if you have a proper request form. And generating a request form or a report for that matter depends a lot on the request form. And to get the required contents filled up in your request form is the onus lies on you. So if you have a good principle wherein you see that you get all the things done like checkpoints, so you will get a good request form. Or always, I'm sure, phone a friend and I'm sure you can fill that all. The second point is the clinical information. A small data of the patient's, why the patient had to have a biopsy. There must be a symptom, there must be a finding on based on which a biopsy is done. That needs to be added on to the report. That's very essential, and maybe there could be something investigation which you have found useful. You can add it on here so that it will add value to your report. The gross description. Every tissue that comes to you has to be described because for many reasons, because you will have to know how much of what is the size, what's the color, so that you can, it is like someone who has not seen the tissue, but by reading your description must be visualized what one received in the lab. And the fourth is a microscopic description. It's the same way. You describe it very precisely, not too long, maybe some 2-3 points, positive as well as negative points. Both are essential. To start with this positive, what is there in the slide? What is that you look at? What is that? What are the findings? Maybe they are important. Yes, diagnostic characteristic. Yes, you describe those. And maybe you were looking for something and you didn't find it, and that is relevant. That needs to be mentioned. So this is very important because if someone reads your microscopy, must be visualized what you looked under the microscope. So in other words, the report that you give is something what has happened in your lab from the moment it has reached and from the moment you diagnosed and you approved and released the report. And the most important, after the microscopy is, of course, is the impression. Impression comes with a comment. Impression is you summarize the morphology to a one-liner saying this is what it is. And the comment is based on that, what is that you want to tell the clinician? This I find that more very useful, and most of for the surgeons or the physicians who look at the report read comment very, very carefully. They wouldn't be reading your microscopy, but they'll definitely look at your impression and the comments. Comments are very, very essential to the report. So with this brief prelude, over to the cases, the 6 cases. And the first case would be discussed by Dr. Aishwarya. Over to Aishwarya. She's from JNMC, Belgaum.
Thank you, ma'am.
Oh, I need to stop sharing. Just.
Ma'am, may I start?
Yeah, sure. Please, Aishwarya.
Yes, ma'am. Good afternoon, everyone. I'm Dr. Aishwarya from JNMC KLE. So the case allotted to us was case number 1. That is excised axillary nodule for histopathology from a 54-year-old female. So here the microscopy of the section shows 3 lymph nodes, 2 large and 1 small. 2 large and 1 small. They are enclosed in a nice fibrous capsule, surrounding which there's plenty of adipose tissue and some amount of skeletal muscle and blood vessels that contain RBCs and hemocentrin-laden macrophages. The architecture of the lymph node is effaced. That is, it is completely replaced by, partially replaced by many granulomas of varying sizes. So there's no distinct cortex or the medulla seen in the lymph node. The pale eosinophilic areas, those are the granulomas. They are composed of aggregates of epithelioid cells that are forming nests and then coalescing to form sheaths. And and they are interspersed between the lymphoid follicles. The lymphoid follicles have no germinal centers. So the multiple granulomas that are present, they are naked granulomas. They are not surrounded by a proper rim of lymphocytes and fibroblastic proliferations. And these granulomas are consisting of epithelioid histiocytes. These epithelioid histiocytes have cells that have indistinct cell borders. They have abundant pale eosinophilic cytoplasm. The cytoplasm contains nuclei that are oval to elongated with prominent nucleoli. So the granulomas also show presence of multinucleated giant cells inside, which are large cells with abundant eosinophilic cytoplasm with many nuclei present within the cell. Now, these multinucleated giant cells, some of them have nuclei interspersed in the center of the cell itself, and some of them are haphazardly arranged, but some of them are present towards the peripheral rim of the cytoplasm of the multinucleated giant cell, forming a Langhans type of giant cell. And some of these giant cells have a conchoidal basophilic inclusion seen within the cytoplasm of the giant cell itself. So these are called Schauman's bodies. Some of them also have some eosinophilic stellate-shaped inclusions present within the cytoplasm itself. Some are not that distinctly formed. So I was not sure if these are asteroid bodies, but this looks like a definite asteroid body. Now, some of them also have these refractile material that are jelly-like. So these could be the foreign body multinucleated giant cells. There's also areas of fibrosis seen within the lymph node architecture and areas of hyaline deposition, that is hyalinization seen within the lymph nodes. So my impression is non-caseating granulomatous lymphadenitis. And since we do not have further information about the history, the clinical examination, and the tests that are done in this case, my differential diagnoses are sarcoidosis because of the naked non-caseating granulomas, foreign body granulomas that would be probably, since this is from the axillary lymph node, silicon granulomatous lymphadenitis, tuberculosis, leprosy, and sarcoid-like granulomas that are seen in underlying malignant conditions or systemic diseases. But TB and leprosy have caseating granulomas, so I would go more towards sarcoidosis or foreign body granulomas. Also, I just want to add a point that in our country, since high incidence of TB is present, TB should be considered as a differential diagnosis of all granulomatous diseases. And foreign material in a sarcoidosis granuloma does not exclude the diagnosis of the sarcoidosis itself. Thank you.
Yes, Aishwarya.
Yes.
Yes, that has been one very good presentation of yours. But I just have a few questions to ask you.
Yes.
Is it possible to go back to your slide?
Yes, ma'am.
Or shall we use the morphel and try to bring it up? Can you all see it? Is it visible?
Ma'am, your screen is invisible.
Sorry, it isn't visible?
No, ma'am.
Okay, just a minute. Okay, is it visible now?
Yes, ma'am.
Okay. So as Aishwarya rightly said, there are 3 lymph nodes, 1, 2, and 3, right? And to begin with, she said, yes, Aishwarya, you said, yes, Aishwarya, architecture. Can you comment what is effaced here?
Ma'am?
Yeah. What you mean by the word effaced?
Ma'am, the normal architecture is replaced by some other material. So normally in the lymph node, it is supposed to show the cortex full of lymphoid follicles and the medulla. But here you can see the cortex is not really present. Even in the cortex, there are many eosinophilic areas seen other than the lymphoid follicles itself. So it is not a proper normal lymph node architecture that is seen.
Okay. If I can tell you something, you know, the word we use effaced only when you do not make out one particular, that is, you should be able to see a capsule. Are you able to see a capsule? You're sure this is a lymph node?
Yes, ma'am.
Yeah, there is a capsule all
Yes.
around. That's why you're able to see the adipose tissue distinctly. And I can go higher on it. And if you go closer to it, you see what is very important is that, do you see this particular space filled with a few histiocytes? What is that?
Ma'am, the
Can you say what
subcapsular.
it is for the juniors?
Ma'am, the
Yeah.
subcapsular sinuses that are
Yes.
present under the capsule between
Yeah.
the cortex.
Did you find subcapsular sinus in these lymph nodes?
Ma'am, they were, that was also filled with all the granulomatous reaction. And
Yes.
there was a lot of lymphocytic infiltration also seen in the subcapsular sinus.
Yes. So you're very right, but you cannot use the word effaced because where there are no granulomata, you're able to see the sinuses. And probably you're not able to see the differentiate between cortex and medulla because there are two lymph nodes which are jam-packed with granulomas.
Yes.
And also it depends on the cut. So you get to see medulla when the cut goes through the hilum, right?
Yes.
That is when you can differentiate. Otherwise, you will be seeing only cortex. Then you say, I don't see medulla. And the follicle, germinal centers that you want to see in this all depends how much is it being stimulated. So I feel here we have a lesion in these three lymph nodes. And if you believe it or not, even this little fellow, so small, is also having a granuloma, right?
Yes.
So, and this one, is it a lymph node? Yes, because you can see a sinus here very distinctly. So these are three lymph nodes with architecture, which is probably could be said that it is replaced by numerous epithelioid granulomas. Okay. The next question to you, you said was they were non-caseating. Right?
Yes,
That
ma'am.
means to say some showed necrosis, which I think here it is very well seen. I think so, if I can. It's showing early necrosis, but what type? Could you specify? There are three types, of course, as you say. One is, can you say the first one is?
Ma'am, coagulative necrosis.
Coagulative. Is it coagulative? No.
No, ma'am, it's not.
Because your morphology is well preserved. Coagulative is something which is ischemic in nature. When you see no nuclei, that is where it is liquefied.
Yes.
Coagulative. Liquefactive is you see some debris here. Sorry. Yeah. And probably this is liquefactive, but can it be caseating? The word caseating? You said it is not caseating, but what would you see if it is caseating?
Ma'am, if it is caseating, we would see amorphous homogeneous areas within these granulomas.
Yeah, and may see with nuclear debris, right?
Yes.
So that is a combination of both liquefactive and coagulative, which we are not seeing. This is more likely to be liquefactive. Yeah. So your use of the word non-caseating is acceptable in this situation. Now, you said they are naked nuclei, a naked granulomata, right?
Yes, ma'am.
But you have anyway the lymphocytes all around, but I'm not sure how well you can really say that they are naked. But one thing I can say is they are multiple, they are small to little larger, and some are discrete, and many are confluent.
Yes, ma'am.
See, there are multiple small and some have become confluent, and you have your giant cells which are scattered all through. There's no definite place for them.
Yes, ma'am.
So, so apart from this, I think your points were very well taken. If there's anything the others would like to add on, Harshita, Gina, Ankita, can we are there any eosinophils? Can these be foreign bodies or any parasites or anything else because they don't look normal? So is there any tissue response to these? Anybody? Can anyone add on? I'm looking for something, one additional point. Is this so-called granulomatous inflammation restricted only to the node?
Surrounding tissue.
Do you think these lymph nodes would be matted? See, here it is. Can you see my cursor, Arshita, Aishwarya?
Yes, ma'am.
No, ma'am.
No. Okay.
Yes, ma'am. Now I can see.
Now you can.
Yes.
Okay. So here is some amount of infiltrate which is going out, but you have naked granulomata sitting outside in the perinodal tissue. I saw it somewhere very, very distinct. Okay, probably here. So there is perinodal extension of this element. So now I'll just take you over to my PPT slide. So is my screen visible?
Yes, ma'am.
So you had 3 by 3. Yes, counting of the lymph nodes very important.
Yes, ma'am.
And we said discrete and few confluent granulomata with all those structures which you illustrated beautifully. They were Schaumann laminated rounded bodies. You had those, probably they're asteroid bodies, very rare to see. I thought it's a beautiful slide for someone to figure out what all one can see in probably a granuloma, which we figure out what it is. There is minimal liquefactive necrosis in a few, and there is perinodal extension. And the rest of the parenchyma, I would say, showed normal architecture. Okay. On this point, what suggestion would be towards the impression? Mind you, these are axillary lymph nodes showing these, and you would say, we being in the tropical country, first thing is you want to rule out a confirmed tuberculosis. And of course, has all the features, small granulomata, and very favoring sarcoidosis, and probably other causes for granuloma. Yes, Aishwarya. Now, I'll show you the diagnosis which have been brought up by the others. Shall we try? Sarcoidosis, let's see whether it is sarcoidosis. Okay. So what would you say? Can this be sarcoid? But you gave me a whole lot of differential. Are you a favor sarcoid or no?
Yes, ma'am. I would favor sarcoidosis more than anything else because of the Schaumann bodies that were more than any other
Okay.
finding.
Okay. For a diagnosis of sarcoidosis, it is not done purely on histopathology, Aishwarya. It needs to be correlated, yeah, with the systemic findings. So you needed to find out many more things of this patient. Okay, we'll quickly go through what the diagnosis which have been brought up. I would say sarcoidosis is a diagnosis of exclusion. Okay, so that means if you have excluded everything and you are left with nothing, maybe it is sarcoidosis, provided it fulfills the criteria of having systemic manifestations or systemic symptoms. So The third is you will have to rule out all this as you had listed out. So we have a big job at hand. And also you ask for serum ACE levels. And for people who will wonder how one will have angiotensin converting enzyme coming up in so-called sarcoidosis, is said to be that they are released by the epithelioid cells. That's something strange and nice to know. But in the early stages, the ACE levels may not be raised. So you may not be helped, by this serology. And of course, they could be systemic manifestations. Most important is bilateral symmetrical lung infiltrate. So you need to ask whether this patient had an X-ray and whether there is mediastinal lymphadenopathy, hilar lymphadenopathy. All these is very essential because if axillary can show, I'm sure hilar and mediastinal would definitely be involved if this is sarcoidosis. The others were put up are toxo. Do you think it could be toxo, Aishwarya?
No, ma'am. Toxoplasmosis would have some suppurative changes also in the granulomas.
What kind of suppuration you mean? What is suppuration?
Like an abscess formation. A lot of neutrophils would be there.
Yes, they would be nuclear debris. Understand they would be necrosis, but they will also have granulomata which are small.
Yes.
And mind you, in your section, it's difficult to find inclusions of toxo. And how would you then make a diagnosis of toxo?
Ma'am, for toxo, we have to do PCR and ask about the history also, especially if it is, they might be cat owners. So that is an important history.
And try to get a serology done.
Serology.
Okay. So it is just a suggestion. Probably it has to be figured out with more investigations. So, and the foremost is in toxo, you would get follicular hyperplasia, you get small granulomas packed within the follicles. That's very, very interesting. Within the follicles, you will find this granulomata and you will have sinuses with monocytoid cells. So your sinuses will be loaded with sheets of monocytoid along with follicular. So there is both sinusoidal and follicular hyperplasia with granulomata. Someone said filariasis. Do you think that it could be filariasis? Maybe those structures which you figured out, they said maybe they are filariasis, filarial parasites. Do you think so?
No,
Aishwarya,
ma'am.
I think
We
I
couldn't
lost you.
see the proper sheath and the granules present in the filaria.
Okay. Another point is in filariasis, if they are dead, that is when the reaction really happens. So we did not find eosinophils. You find them all calcified. You find them if they were so-called lifeless, So, but I don't think it is filariasis because there is no such morphology to it. Though there was a little fibrosis at the end, but I'm sure it is not fitting into filariasis. MAI infection. Someone thinks it could be tuberculosis with intracellular A type.
Yes, ma'am. This could be one of them.
How would you defend yourself?
Ma'am, this could be actually one of the potentials because since the granulomas seen in these atypical mycobacterium are non-caseating type. So that could be one of the reasons. And there were few Langhans type of giant cell, but the granulomas are well formed in this case, ma'am. Whereas in atypical mycobacterium, they'll be ill-formed granulomas more.
Yeah, and moreover, I think your ZN would be really helpful. Let us see what happened to this case. We are still in the differential. We do not know what happened to the case. So in addition to MAI, you will find lots of myofibroblasts, lots of spindle cells, and you will find that it is loaded with the acid-fast bacilli, and the patient is most likely to be HIV positive. Okay, so what do we do next in this case, Aishwarya?
Ma'am,
What do you want to do?
Ma'am, first would be to take a proper detailed history. Like
what is that you want to know? Be
ma'am,
quick and fast.
I would definitely want to know if there were any illnesses that she had, for example, any cough, fever, or anything, just to know if TB could be one of the causes. And since I'm
She didn't
suspecting,
have any of those. You ask me and I'll tell you. Okay?
yes, ma'am.
Okay,
Ma'am,
there were none.
I also want to know about any silicone gel that was used for her breast implants.
No, no. She is purely a typical village South Indian female. I don't think she knows what is silicone. And I don't think she had an implant.
Ma'am, any underlying any other diseases like rheumatoid arthritis or autoimmune diseases like Sjogren's syndrome?
No. She was elderly, but she's elderly, but I think she was physically fit with no such ailments.
Ma'am, any known case of carcinomas, especially breast?
Why did you take that long to think of breast lesions?
No, ma'am. The granulomas that are present, they had lymphocytes interspersed between the epithelioid cells. So I did think of sarcoid-like granulomas that is usually seen in underlying female genital tract malignancies. So
Okay.
I would
Anything
like
else
to
that
rule
you
out.
want to know? Let me ask the surgeon and tell you.
Yes, ma'am.
Any other?
A
You're
TB.
done?
Yes, ma'am. TB and leprosy, I would like to rule out as a hard and fast rule, given that we are in India.
Leprosy, this kind of morphology, cytoplasm of those epithelioid cells will be vacuolated. It could be tuberculoid type, right?
Yes,
But
ma'am.
then a lymph node, I mean, the way it would present would be different. I
Yes,
can
ma'am.
tell you Z1 was done on the slide, it was negative. More meticulous examination of the patient is required. I would say phone a friend. I acted as your friend, but I'll tell you more details. And then what happened was, it's a lymph node. You have to look at the areas which are drained. You should ask me, how is the breast in this lady? How is the lung or the mediastinum for any pathology? Anything to do with axilla, look at the area that it's going to drain, So, and of course, ACE levels. In this case, ACE levels were normal. But that doesn't deter you from making a diagnosis of sarcoid if that is in your mind. Because early stages, you may not get increased levels. So the story continues. Yes, I called my friend. You know who my friend is?
Surgeon.
I said, phone a friend. I did. That's the easiest. Yes, and that is my clinician who sent the biopsy. And he said, yes, this is a case of CA breast as you thought it was an infiltrating duct carcinoma of grade 2. The patient had a 2.53 centimeter big lesion in the breast, but it was palpable with difficulty because she was obese. Okay, anyway, and there were lots of lymph nodes in the axilla, so much so they thought it was N3. Okay, involved with tumor, no meds, of course, ER negative, PR, and HER2 negative. And then they had 12 lymph nodes and they were all granulomatous, each one of them. And mind you, this patient had not been started on any treatment. She preferred this than go on to NACT. Okay, she didn't. Now, as we had these issues, all 12 granulomatous lymph nodes were AFP negative. And we did pan-CK. Do you know why we did pan-CK?
Ma'am, CK can be done for any epithelial tumors, spindle cell.
Why in this case? Because the granulomata can appear to the metastatic carcinoma cells to the lymph nodes. So it may be a very good host response. But they say maybe cells or it is the tumor antigen to which you have a granulomatous inflammation. But it's mandatory that you do your immunocytokeratin to prove that these lymph nodes are free of malignancy, right? And in this case, it needs no treatment for the granulomatous inflammation because they were tumor negative, AFP negative. On the whole, they have just treated for her for the CA. So this lesion, the so-called what you saw, 3 lymph nodes with granulomata, could be associated with in their regional lymph nodes, in the lung, colon, stomach, testes, thyroid, any one of these organs. So don't get perturbed when you see this granulomata. And then if you see one, please call up your friend and find out why was this lymph node sent. Okay. In this case, this came as a slide and block consult. I was amused when they wanted to know whether it was COX. When I got the history, then I knew that they were expecting that we would say these lymph nodes were positive for tumor. So they were wondering, they have called it N3 and why is this N0? Okay, the final diagnosis is the word sarcoid-like reactive lymph nodes in an untreated case of CA breast. Okay, so the word is sarcoid-like reactive. We use the word SLR for short, is used when these patients do not have symptoms of systemic symptoms of sarcoid. Okay, this is a local response. So what appeared to be granuloma, it is now a sarcoid-like reactive lymph nodes. We got more history by speaking to the clinician, and that we know it's related to CA breast. I didn't hide anything from you, and this is how I got the history and the slide. Okay, talking to your friend on the other side made a lot of difference to the patient, because he or she is not going to be treated for it. Okay, Aishwarya, I hope you have, we had a good discussion on this slide.
Yes,
Okay,
ma'am.
any doubts from anybody? Can we move to the other? Here are some of the references if people would like to go through. This is just the pre-proof. Please go through them. They are nice articles and there are a lot more, but it's a very beautiful case to learn. Thank you, Aishwarya.
Thank you, ma'am.
Thank you. We go to case number 2, Harshita from ESI Hospital and Research Institute.
Yes, ma'am. I'll share my screen.
Probably I need to, I should stop sharing. Yeah, is that okay?
Yes, ma'am.
Yeah. Harshita, it's taking time to start. Yeah.
Is it visible, ma'am?
Yeah, I can see your slide.
Okay. Good afternoon, everyone. I'm Dr. Harshita Umesh from ESIC Medical College, Bangalore. I am presenting case number 2. The history given was perianal abscess drained from an 18-year-old female for evaluation. The section study showed 4 tissue bits. One of the tissue bit showed a structure of skin lined by keratinizing stratified squamous epithelium, and a foci of this epithelium showed hyperplasia. Subepithelium showed chronic inflammatory cell infiltration by lymphocytes, plasma cells, and giant cells. This is a microphotograph showing for lymphocytes and plasma cells and giant cells. Another tissue bit showed epithelial ulceration and a band-like infiltration by the inflammatory cells of the superficial dermis extending into the epidermis. This is a portion showing ulceration, as well as the band-like infiltration of lymphocytes and plasma cells in the superficial dermis and extending into the epidermis. Also seen are giant cells. Also seen were thickened blood vessel walls, perivascular lymphoplasmacytic infiltration, and numerous proliferating blood vessels. And a few areas showed vegetable matter. With this, I would like to give an impression of primary syphilitic lesion. And also a close differential diagnosis would be anal tuberculosis. As anal tuberculosis is one of the extremely rare extrapulmonary presentation of tuberculosis. There are some supporting articles or case reports which were published with respect to anal tuberculosis presenting as perianal abscess. And these case reports concluded that less than 1% of individuals who contract tuberculosis manifest as anoperianal tuberculosis. And in tuberculosis endemic regions like India, it is recommended to rule out tuberculosis as the main, as the first diagnosis when there is a non-healing and a non-healing recurrent lesion in the anal region. I would like to highlight on common causes of perianal abscess, which includes infected anal fissure, sexually
Excuse me,
transmitted.
Harshita. I don't
Yes.
want differentials. Okay. I wanted you to emphasize on the morphology and
Yes.
yeah, if you can quickly skip it through is way good enough. Your
Yes.
differentials were tuberculosis. Anything else?
That's all, ma'am. Anal tuberculosis and syphilitic, primary syphilitic lesion.
Okay. You said something to do with trauma.
Yes, ma'am.
I saw that you had a word. It's a
Perianal
traumatic
abscess.
lesion.
Yes, ma'am. Other causes of perianal abscess are infected anal fissure, sexually transmitted disease, trauma, and blocked glands in the anal area.
Okay. Okay. I just want to know if any of the others would like to add on anything more. We'll start with Gina. Gina, you have anything to add on to this slide? Do you agree with what Harshita says? Any other finding? Or you want to, or you agree with whatever she has said so far? Or you want to say no? It's your session. We can't hear you. Sorry, I think you should unmute.
I would give only a
Little
professional
louder,
diagnosis.
please.
Would give only a professional diagnosis.
I can't hear you. Sorry.
Hello, ma'am. Can I?
Yeah. Now I can hear you, dear.
Yeah. I would give only a professional diagnosis before
No,
calling
you're
it
very
syphilis.
feeble.
Before calling it as syphilis. Yeah.
No, I didn't hear you. Sorry.
Uh,
I can't hear you. Can you be as loud as Aishwarya? I'm a little short of hearing.
Ma'am, can you hear me now?
Yeah.
Yeah. Yeah. I wouldn't call it syphilis in with this itself. I would ask for more investigations. Yeah.
No. I'm asking about morphology. Do you agree with whatever she has said?
Yes, ma'am.
Okay. Archita, do you want to, do you agree with what Harshita has said? Arijita, come on.
Yes, ma'am.
Yeah, I can see you there. You're on. I want to know, do you agree with whatever she has said so far? Who, Harshita?
Ma'am, there are few areas of mucosal ulceration also, line by 15.
Yeah. Okay. So there are areas of ulceration. There are about 6 fragments. If I can go through the morphal, let me see if I can show you the slide. Yeah. If I remember, yes, this is the slide 2. Yes. I want people to let me know what is this called, Harshita? This.
Your screen is not
can't
visible.
Oh, sorry. I'll go back to and then share. And it sorry, no. Yeah. Is it okay? Can you see it? Can you see the screen?
Yes, ma'am.
Yes.
Yes, ma'am.
Yes, ma'am.
So there were so many fragments. Actually, there are two sections. Okay, we have 4 plus 2, 6 fragments. We'll take the larger fragment. And this is what kind of epithelium is this?
Recognizing stratified squamous epithelium.
Keratinizing
Stratified
stratified
squamous.
squamous cells.
Squamous epithelium, yes. Can this be called epidermis?
Yes, ma'am.
Yes, madam. Epidermis center.
Maybe we'll use the word anal skin. Okay. And if you look at this, there are whole lots of, congested blood vessels, which is part of the surgery. But if you look, there is some cautery effect. I'm not very impressed by this fragment. I don't find anything good in this. Okay. This is what maybe, did you find any other epithelium other than the anal skin?
No, ma'am.
Yeah. She pointed out to granulomata. Yes. There are multinucleate giant cells.
Yes.
Yes, ma'am.
I think this is the one, if I remember. Yes. Here there are some multinucleate giant cells right over there. This is ulcerated. It is covered by fibrinous exudate. So we do not know what epithelium was here. Probably anal or transitional mucosa. It is a perianal abscess tissue that has been sent. Okay. So we find that there's little bit of squamous epithelium, but you find scattered multinucleate giant cells, but no distinct granuloma as such. But maybe there are forming an incipient granuloma. See, this is an incipient granuloma. This is a multinucleate giant surrounded by these. So you have a lot of inflammation around it, bound to be because it's ulcerated. But if you look at the other blood vessels, it is perfectly normal. These are the deeper vessels which are little muscular. I wouldn't be worried. So any other finding other than these? So we have a perianal tissue, which is said to be from an abscess. So what more history do you want, Harshita?
Ma'am, tuberculosis, to rule out tuberculosis, ma'am.
Okay. Okay, I would say yes. How would you want to rule out tuberculosis in this 18-year-old girl?
Evening rise of temperature, history of contact with tuberculosis.
There is none. Anything else?
Go for the gender.
Anything else? Quickly. Okay.
Any
Now, can you
infection?
see my screen, Harshita?
Ma'am?
Any other details you want to know other than whatever you have asked me? Okay. So to take it on to this, can anyone see my screen? Yeah.
Yes, ma'am.
Is that visible?
Yes, ma'am.
Please let me know.
Yes, ma'am. It is visible.
Yeah, okay. So this is a perianal abscess or whatever has been so. We have seen striated squamous with multifocal ulceration, stellate multinucleate giant cells, random granulomata as we described. But there is no obvious necrosis. Now, one thing what we need to know is always when all this is happening, you want to know there is any vasculitis because clinician was a little worried because this child was not doing well. There were a little rashes on the skin. So he was wondering whether it was vasculitis. But I said, yes, can we comment on vasculitis on this biopsy? Are we correct in commenting on vasculitis? It is not, because there's so much inflammation because of surface ulceration. We wouldn't be talking on vasculitic process. So the AFP stain was negative, Harshita. Okay.
Okay.
Now, anything more you want to know from this? So to add up to your differentials, there were a lot of other diagnoses which were brought up in the group. Someone simply said it's an anal abscess. Okay, lot of inflammation. Must have been ruptured abscess. Okay, fistulous tract. You know, the surgeon himself will tell you that there was query fistula. So I don't think our diagnosis should be a fistula, right? He wants to know, having sent the fistula tract, what is that you want to say on this patient? Foreign body reaction. Did you find any foreign body?
Yes, ma'am. There was, I thought that was vegetable matter, ma'am.
Where was it?
One of the tissue which showed that.
Correct. But
that,
if you look, it was on the surface, right?
Yes, ma'am.
It was not within the tissue, right?
Yes, ma'am.
So mind you that it is a perianal, so it is exposed to all those fecal matter, and I'm sure there's little bit of stuff might have been on the surface, and that must have got scooped out, I feel. But it was not inside a granuloma to answer your foreign body granuloma. Agreed?
Yes.
Yeah.
Yes, ma'am.
Vascular malformation. The blood vessels seen were perfectly normal. Other than that, they were congested, which is part of the surgery that the child has undergone. Someone has seen Entropias vermicula. Did you see it, Ashita?
That vegetable matter which was seen can be mistaken for Entropias vermicularis.
But it doesn't have the structure, right? For that,
Yes,
any of those classes or pictures, if you Google up, I'm sure you will get a nice Entropias with area on either side or whatever. You will see muzzle wall. We didn't find that was vegetable, whereas this should have little muzzle in its content, right? It is not. Someone said Crohn's. Do you think it can be Crohn's?
No, Crohn's will have granulomas, ma'am. There was no
But I showed you a granuloma. I showed you, no?
Yes,
Neat, distinct granuloma.
Yes.
So can it be Crohn's? Okay, so, and then somebody said interstitial cystitis. I'm sure they got confused with the next slide and they inadvertently called this interstitial because there is no urothelium here, no bladder tissue. I think this is just a wrong place of entry of the diagnosis. So I just thought, I'm sure you would have also looked like the way that I have, you would have done. I thought perianal granuloma with Entropias. There is a nice article which talks about perianal disease and granulomas. They out of the box. Okay. So there are a lot of things that come up, a whole list. But you as a pathologist, which I say, yes, you have a big job how to exclude one from the other and come to the probably the right answer. So now, what do you want to do next, Harshita? We have so many differentials. We had a DDS. What do you want to do?
Tuberculosis.
Anything?
Ma'am, for my diagnosis, I want to roll out with serology, ma'am.
Yeah, serology. Yes, I will do one thing here. Okay, the child had a severe microscopic hypochromic anemia. But to answer your question, okay, you wanted to know ZN, it was negative. Stool examination was negative for overcyst because I'm trying to, having had TT, now what all was being worked on the case. I'm just showing it to you. And the child had lost weight 3 kgs in 2 months, which I thought she was an adolescent girl wanting to be trim and, look smart. So she must have reduced her diet or water modified her diet. But what I would do is phone a friend. So if you call your friend, who is your friend, Ashita?
Surgeon.
The person who
Physician.
sent you the biopsy. Okay, you call him or her, and what will you ask? Yes, he won't wait on this side like this. You'll have to ask questions 1, 2, 3, 4. What are the doubts that you have? You had so many differentials, right? You have sorted out with a few tests that we did. Anything? So I would call my friend and I said, can you describe the fistula if you have curated it, right? So she drew this picture across and she told me, this is a long track and here is the anal abscess, perianal abscess. This is the anal opening. So it has been descending. So it's quite a long one if you really look. So it's a fistula probably arising in the lower rectum coming up to the anus. Okay. And next, what do you want to know? She told you this. Now, with all this put together, what would you like to do for this patient? Syphilitic lesion? She said, okay, I'll ask. And she said serology was negative. Sorry, it didn't occur to my mind. But they have not done it, but she's doing well now because that was not at all in their differential because the histology was not of syphilis and primary syphilis. They're all very rare of late because of the very good antibiotics that we have in the market with the 3rd generation. So, okay. Oh, sorry. Okay. So what did I ask for? Is an endoscopy. Okay. I requested, is my slide, yes, Ashita?
No, ma'am, it's not easy.
It is not. Okay. Okay, is it seen now?
Yes, ma'am.
Yeah. So I said, yes, please, looking at the recto-anal whatever fistula that we have, I said, please do a colonoscopy on this child. And they did find linear serpiginous ulcer with few skip areas with the entire cecum and descending colon showing cobblestoning. Look at the cobblestoning and the
Yes.
nodularity which is seen, and you have deep clefts in between. Look at the corrugated surface on the top, right? So they said ileocolic or colonic ulcers present, and they said to rule out Crohn's. And as they did it, they took biopsies. Okay. So the mapping colonic biopsies were taken, of which I will try to show one of them. Okay, I'm showing it under the microscope. Can you see the images?
No, ma'am,
Is
the
it
screen is
visible?
not shared. Ma'am.
It's not shared. Just a minute. Is it shared now?
Yes, ma'am.
Okay. So here is the mucosal bits. From the cecum. So you see the colonic mucosa. What is this, Hashita? Lymphoid aggregate, right? Okay.
Yes, ma'am.
This is the surface mucosa. Do you find that the crypt architecture is maintained? Is it maintained?
Yes, ma'am.
Okay. And what is that you're seeing here? In the center?
Lymphocyte aggregate, ma'am.
Sorry?
The lymphocyte aggregate and
Lymphocyte aggregates. I go higher on it. Do you see anything better? You see a follicle in its center, right? They are all follicular center cells forming a germinal center within the follicle, within the lymphoid aggregate. And what next are you seeing? What next are you seeing? What is this?
it is blank, ma'am. Not able.
What are these? There is an area where there are no glands, right?
Yes, ma'am.
And what is in the center?
Giant cell.
This?
Giant cell, ma'am.
They are multinucleate giant cells.
Giant cells.
Okay, and they are rimmed by the lymphocytes. Anything you want to add on to this? Ankita, you have anything you want to say on this?
Hello, ma'am. Nothing, ma'am. Multinucleated giant cells are surrounded by lymphocytes.
Yeah, and there are a few epithelioid cells by the side. Okay, so this is a mini granuloma, right?
Yes,
it's a minute granuloma within the mucosa of the cecum. Now, can you conclude anything on this biopsy? So you have your mucosa with the crypt architecture well maintained, but you see that lymphoid aggregates are quite prominent. And here is another granuloma. If you look nice, here is your granuloma. Not very, very clear, but you see giant cells here. And there is a big multinucleate giant cell. So can you put things together, make a diagnosis in the clinical context?
Crohn's disease.
You want to? No, I don't want one-line answers. I told you pathology is not one-line answer. Okay, so we have we see here that they were non-necrotizing microgranulomata. We're showing ulceration at foci with cystitis, and it is diagnostic of Crohn's disease. So putting things together, Crohn's disease here presented as perianal fistula. So the lesson that you learn here is especially that anything to do with granulomata, it is not that you have to work it out. You have to evaluate the patient and so much. So, you have to guide the physician, say, can you do colonoscopy on this patient so that we get a diagnosis? You would have said colonoscopy is normal. Then I know that you would have looked for something else. But here it was very imminent, the history, the rectoperianal fistula, all that in a child goes in favor of a Crohn's disease. So the point that we have to deal here is how do we pick up the granulomata? where do we look for granulomata? And suppose this granuloma was in the stomach, it is a clear-cut diagnosis of Crohn's. You know, you don't have to have in colon, but that's how many people go with. If you can pick up a microscopic or a small granuloma in the mucosa, in the gastric, in a child, you know, it's very well tells you that maybe, yes, I think it has to be Crohn's. So these are the few things that we need to remember. So thank you, Harshita. So I hope this case was instructive in the sense that when you see something to do with the perianal, you rule out all the causes, but do remember that the child having had anemia, having lost weight, put things together, ask for colonoscopy, and that is where it's helpful. So the here clinician who was asked to do it, earlier it was being treated by the surgeon, so the case went to a physician for further management. So we go on to the case number 3. This is dealt by the Gina from KMC Manipal. Thank you, Harshita. Thank you.
Thank you, ma'am.
Dr. Gina?
Dr. Gina, are you there?
Yes, yes, I can't share.
Just tap on the share button. Please come back.
Freeze.
The screen is freeze, is it?
Yeah, yes, sir.
Just try refreshing once, or is the share button working?
I'll join again.
Yeah, just log off and join again. No issues.
In the meantime, should we go to the slide number 4?
Yes, ma'am, we'll do that, ma'am. We'll move to slide number
We'll do
4.
that.
Gina, please log off and join that.
Yeah, the 4th slide will be by Dr. Arijita from Davangere.
Yes, ma'am.
Yeah, you should introduce yourself, please.
Yes, ma'am.
We can't see you, Dr. Arijita.
Please start your webcam also, Arijita.
Yes. Yes.
Yes. Make it full screen and please introduce yourself and start off.
Yes, ma'am. Is it visible, ma'am?
Yeah, I can see you.
Okay, ma'am. Good afternoon, everyone. Myself, Dr. Arijita Bani, presenting case number 4 from JJMMC Davangere. History given is bone tissue sample from breach in left lateral femoral condyle following arthroscopy in 52 years male. HN is stain section from multiple bony tissue beads in low powered view showing bony trabeculae with intervening fibrocellular tissue. Lesion is composed of sheet of foamy histiocytes. On higher magnification, these foamy histiocytes have distinct cytoplasmic border, abundant pale eosinophilic granular cytoplasm, and small pycnotic nucleus. Also seen diffuse inflammatory infiltrate composed of lymphocytes, plasma cells, few polymorphs, and multinucleated giant cells. This photomicrograph also shows sheet of foamy macrophages, aggregates of lymphocytes, and multinucleated giant cells. Also seen few dead bony spicules surrounded by fibroblastic proliferation and lymphocytic infiltrate. Area of fibrosis with fibroblasts and histiocytes also seen. Based on the history given of bone tissue sample from breach in left lateral femoral condyle following arthroscopy in an elderly male and microscopic features of sheet of foamy histiocytes, diffuse inflammatory infiltrate composed of lymphocyte, plasma cell, neutrophils along with multinucleated giant cell and fibrosis. My two closest differentials are xanthogranulomatous osteomyelitis and Ardem-Chester disease. Before concluding, I just want to say the similar and dissimilar features of xanthogranulomatous osteomyelitis and Ardem-Chester disease. For xanthogranulomatous osteomyelitis, there is no characteristic age distribution, whereas for Ardem-Chester disease mainly occur in adults with mean age of 55 years. In both the cases, there is male preponderance. Xanthogranulomatous osteomyelitis mainly affects long bone, and for Ardem-Chester disease, most common site is long bone of lower extremity. Microscopic features of Ardem-Chester disease is infiltration of foamy macrophages admixed with lymphocyte, plasma cell, neutrophil, and multinucleated giant cell, which is indistinguishable from xanthogranulomatous osteomyelitis. Foamy histiocytes of xanthogranulomatous osteomyelitis are positive for HAM56, CD11B, CD68, and eosinophilic granules are path positive. Whereas for Ardem-Chester disease, histiocytes are positive for CD163, CD68, CD14, and negative for CD1A and 207. Thank you.
Yes, yes, that was a neat description, Arijita.
Yes, ma'am.
Thank you for that. You did a good job. But I have
Thank
a
you.
few questions. You said they were viable bone or they were only dead bone?
There were, ma'am, multiple bony trabeculae are there and also bony, dead bony spicules are there, ma'am.
Okay. Can we, I'll just take you to the, sorry.
Dr. Arijita, please stop sharing the screen.
I'll stop sharing, yes.
Thought I'll take you to the slide. I agree with all your points, yes, but you did describe the types of, it's for the juniors, you know, you have your baby juniors there. So I want you to identify a few things. So both the sections, are they similar? I think so, right? So we will take this on. And if you look at it, yes, yes. So we'll start with this one. What type of bone is this, ma? Arijita?
Ma'am, these all are bony trabeculae which shows
True. What
lamellar.
type of bone? What type of bone?
Ma'am, lamellated bone, mature bone, these are.
Yes. Is it viable or dead?
It is viable.
Yeah. How do you say that?
Osteocytes we can see with lacunae and well architecture parallelly placed lamellar
So
bony architecture.
these are the osteocytes, right? They are
Yes,
within the
ma'am.
lacuna. So to tell you that this tissue is viable, right? So you see
Yes.
the lamellae. So it is from the lamellae. This is of the long bone. Which bone are we talking about?
Yeah, ma'am, left lateral condyle of femur.
Femur. Okay. Now what about this? What is this tissue? Is also a lamellar bone.
No, ma'am.
So what is it?
This
So
is,
if it's
ma'am,
not
I think,
lamellar, what you have
open
any
bone.
other? Yes, this is oven bone, right? You
Yes,
see the junction, so it is maturing to form the oven bone, right?
yes, ma'am. Yes, ma'am.
So you think in this gentleman who is an elderly male, should you get an oven bone? Okay.
No.
So this is lamellar bone, right? This is
Yes.
mature lamellar bone. And in between, what you have is loose adipose tissue, which doesn't bother you much, right?
Yes, ma'am.
Okay. But here you see there's a lot of fibrosis. Agreed?
Yes, ma'am. Fibrosis.
But here, if you look, there's a lot of inflammation, right? And here there is something nice. What is it? What are these? You can see my pointer?
Yes, ma'am. Ma'am,
Yes.
these are foamy macrophages.
Absolutely. You're very right. And what about this? What
Yes,
happened?
ma'am.
What can that be in the middle of this?
Marrow element.
Yes, that is the fat, right?
Marrow
The fat
element.
has got trapped in this. If you see, there is lots of these foamy histiocytes as you described. And here is a fragmented bone, which probably is dead, right?
Yes, ma'am.
Yes. So you have viable and dead bone, and you have this kind of cells. And only thing is now I must show you somewhere something else. I hope I don't know where I will see that. What is this lining? Can you see something here? This has come out from somewhere, okay. What about this tissue?
And these look like more
Okay. Here you see there's lot of, what are these?
I can see
Blood
the
vessels, right? They seem to be part of granulation tissue, lots of blood vessels with lot of inflammation, and must be giant cells, you know why? Okay, not able to mark and bring. And in the midst of these, you have multinucleate giant cells. Okay, very good. So when you have both viable and dead bone, diagnosis? You have said that already.
my differentials are, ma'am, xanthogranulomatous osteomyelitis.
Osteomyelitis. Okay, dead and viable osteomyelitis. You see foam cells with giant cells, maybe there's xantho. And then there is that oven bone being formed. I feel maybe it is that tissue is healing. But strangely, later, I'll tell you what happened to this patient. He gave me a history which went very well with it. But there are some synovial tissue, if I remember. I don't know where exactly it is. And there is amount of synovium which is showing ulceration. So this patient went for arthroscopy. They hit the lesion on the periosteum and took out these chips of bone. So your diagnosis is xanthogranulomatous osteomyelitis, right?
Yes.
Now, I'll just take you to the screen. Can you see my slides? Not is it? PPT, can you see my PPT?
Yes, ma'am.
You can see it.
Ma'am, not the PowerPoint. We're still on the slide.
You're still on the slide. Okay. Okay, so just to let you know what were the diagnoses offered in this case. Yeah. Diagnosis offered in this case were granulomatous osteomyelitis. I suppose it's very non-specific. I know it is granulomatous, but one needs to be specific. I think granulomatous osteomyelitis. So everyone got the diagnosis of osteomyelitis. Someone said intraosseous ganglion cyst. Do you agree to that, Arshita?
No, ma'am.
Ganglion cyst. I think they must have got confused with the synovium lining, which must have, I don't know how they made the diagnosis of ganglion cyst. You know, I'm not sure. Fibrous dysplasia. Do you agree to fibrous dysplasia?
Ma'am, in case of fibrous dysplasia, there will be both in peripherally it will be more mature this thing, and at the center it will be immature bony structures. And
But how will
fibrous
be the
spindles,
spicules of bone? And in this elderly male, what an
yes,
age
ma'am.
to get fibrous dysplasia? All
In
bone
younger,
lesions are specific, right? They are found in certain age groups. Fibrous
yes,
dysplasia is seen in
younger
which
age
group? Younger age group. He wouldn't have lived to be, to be of that age. I'm sure he's around 52. He wouldn't have reached without any skeletal problems. And the morphology is there. What kind of spicules of bone that you see? There is a specific terminology for that, and which we are not seeing here. What kind of lamellae would you see in fibrous dysplasia? Okay. Next is, can this be avascular necrosis? See, there's no necrosis here. So there's no term called as avascular. So avascular would be traumatic, but then there is no infarct. You don't see anything. Everything is viable except for the bone which is dead. Someone thought of metal transplant reaction. I'm not sure where they have seen the metal or any foreign body. Did you say any foreign body?
No, ma'am.
No. Okay. So what do we do next in this case? Sign out as xanthogranulomatous or whatever you said. What disease did you say?
Ma'am, to look for infective etiologies, we can do Zarenstein, and culture we can do to know
Okay,
the
they're all
organism.
negative. It was done, it was negative because anything with to do with the granuloma, especially bone, one must be very careful to rule out tuberculosis. Okay, and that too in that elderly patient who was a diabetic. Yeah. Anything else?
If ma'am it is not tuberculosis, then culture we can do.
Apart from that, what else do you need on tissue from bone?
X-ray.
Always. Without it, you cannot sign out a report.
X-ray findings.
Yes, somebody said something.
X-ray findings.
X-ray. Yes, you should ask for an X-ray. I would say without an X-ray, never sign out a report, right? So for that, you have to call your friend, right? Please send me the picture. I will come over. Keep coffee ready for me. Okay, we'll have it over a cup of coffee, discuss the X-ray. Okay, so take your friends along and go there. And here is the X-ray. There is a lesion here just above the periosteum, and that was it. And interestingly, this patient had a little trauma on this part of the thigh, and that led to, and he being a diabetic, I suppose, all put things together, he developed this kind of a response. And as it being close to the joint, so they thought initially it was synovitis, and that was acute, became acute on chronic synovitis. But when he went on to do the arthroscopy, he realized that he was taking out bits of bone which were just falling apart. Okay, so the spicules viable and dead, intertrabecular showing multinucleate giant cells, foam cells, all your findings were wonderful. No distinct granulomas seen, nor even epithelioid cells. So much fibrinous exudate, synovial tissue was there which showed ulceration. So the impression here given was probably chronic osteomyelitis for sure with xanthogranulomatous host tissue response and associated with acute chronic synovitis. No demonstrable causative agent here, but we don't know more about. And we said a tubercular etiology is unlikely here. And this tissue was sent for gene expert and it was found negative. Okay.
Yes.
So there are a few interesting cases, reports for someone to know that it is like xanthogranulomatous osteomyelitis. Another way to look at is whether trauma led to the xanthogranulomatous response, because there is a little bit of fat necrosis over there. So maybe it was, could we say a xanthogranulomatous? Anyway, that was very good, Achita, for your participation in this and quick and crisp morphological description and discussion. Okay, so we go on to the fifth case, that is Ankita from Bellary.
Thank you.
Yeah, thank you. Thanks a lot, Ma. Thank you. Are we on time, Dr. Shruti? Or are we late? Do we need to hurry up? Is it okay?
Ma'am, sorry. I think we need to kind of go
through.
quicker.
Okay.
Yes.
Yeah, we'll do that.
Yes.
Come, Ankita, let's have your slide presentation.
Hello, ma'am.
Yeah, thank you. I can hear you and see your slides as well.
Okay, ma'am. I'll start, ma'am.
Yeah, please.
Yes. My name is Ankita from AVIMS. I'll be presenting case 5. History given to us was midline nasal mass from a 47-year-old male. So the lining epithelium here is squamous, stratified squamous epithelium. Beneath that, there is a ill-defined granuloma consisting of epithelioid cells, multinucleated giant cells, and which are surrounded by lymphocytes. A Langhans type of giant cell, where the nucleus are situated at the periphery with abundant cytoplasm, again surrounded by lymphocytes. We are also seeing a foreign body type of giant cell, where the nuclei are scattered haphazardly in the center. Also, we are seeing here is the blood vessels have undergone fibrinoid necrosis here, and we see a plenty of eosinophil lymphocytes around them. This is another view of the same fibrinoid necrosis of the blood vessels. We also see a mixed inflammatory infiltrate, where predominantly we are seeing eosinophils, plasma cells, lymphocytes, and also neutrophils. There's also a foci where geographic necrosis was present, and there was an area that had cartilaginous and osteoid material. So to summarize, section studied from nasal mass shows stratified squamous epithelium. Subepithelium shows ill-defined granulomas consisting of epithelioid Langhans giant cells and foreign body giant cells surrounded by lymphocytes. Now the blood vessels are showing the fibrinoid necrosis. Also, a diffuse mixed inflammatory infiltrate consisting predominantly of eosinophils, plasma cells, lymphocytes, and occasional neutrophils. Now, deep to this, cartilaginous and osteoid tissue is seen, which is non-viable. There is no evidence of malignancy in the section studied. So I would like to give a differential diagnosis here. One is a eosinophilic granulomatosis with polyangiitis. The features favoring here are plenty of eosinophils, fibrinal necrosis. Vaginas, I would like to give is we are also seeing occasional neutrophils and geographic necrosis.
Okay.
Thank you.
Yes, thank you, Ankita. I just want to know what others feel about. Nagaraju, can you tell me, do you agree whatever she has described is yours too?
Regarding the fibrinal necrosis, I thought some parasite or otherwise fungal infection.
Oh, that's what you think so.
Remaining multinucleated gene cells is there, madam.
Okay.
Remaining everything is okay.
Okay. So we have a diagnosis which says yes, patient needs to be treated immediately. You know, it's vasculitis. And here you say yes, there is fungus. Again, it needs to be treated in a different line. You know, you see the treatment is going to be different.
Because around that fungal infection side, you see the eosinophilic infiltrations.
Okay. Okay. Anything more?
No.
Anything more? Nagaraju, yes. Hashita?
When we had thought of the phase 1 is the fungal infection.
What of the fungus?
Yes.
Okay. Do you agree with that, Ankita? Do you think it was fungus? They're all saying fungus. Do you agree?
No, ma'am.
Let me see if I can share the image. Sorry. I'm going to the section. So this is the epithelium, right? This is stratified squamous epithelium. You're right, no, Ankita? That's what you meant?
Yes, ma'am.
Yeah?
Yes, ma'am.
Yes.
Yes, ma'am.
So the lesion is situated deep within, right?
Yes.
You see the surface mucosa is unremarkable, right? It's not ulcerated.
Yes,
okay?
Yes, ma'am.
Patient seems okay, right?
Yes,
Yeah.
ma'am.
And then you see that there is a lot of blue that you see this because of the infiltrate. Now, I'll take you the higher magnification is what you were saying, right? These are blood vessels, right?
Yes, ma'am. Yes, ma'am.
Okay. Now, let me take you, I have to really search. What is the search? What? You can see my pointer?
No, ma'am.
Yes.
Oh, you can't see me. You can see now?
The endothelium.
Yes, ma'am.
Okay, sorry. So what is this? What is this? To identify whatever I point out. This is nothing but a blood vessel which is collapsed,
Endothelial
lying
cells.
by endothelial cells, right?
Okay.
Yeah. Okay. Now I'm searching for blood vessels. No, I shouldn't be struggling so much for blood vessels. Okay. Here is one blood vessel. It looks like there is positive blood vessel. There is one here, but you know what? What has happened to this tissue here? It's all blue in color, lost structure, identity.
Hello.
This is all by the cautery effect. That is the biggest enemy for a pathologist, histopathologist. This is all burnt. The surgeon has used cautery, so you can't see anything. It's bluish, and all the nuclei have turned blue in color, so it is not possible. Okay, what about this blood vessel, Ankita? Yeah, that looks normal, right?
Yes, ma'am.
So there is a pause, some blood vessel there, let me look what has happened. What has happened is, I'll tell you why we are not able to see the blood vessels so well. They are collapsed is because of this material. What is this material which you said was something to do with cartilage? No. They have injected into the blood vessel something like, what, it makes the blood vessels collapse, and this is iatrogenic induced, so that the tissue bleeds less. Okay, so this is not to be read as something what you called as cartilage, etc. So you see more of this, and that is because the ENT surgeons use that very often, and you must get used to seeing those tissue artifacts. But what you are seeing here is something very striking. See here, you see something in its wall, in the center, it's elongated, and there is something in the center. These are not blood vessels. If you say fibrin or fibrinoid necrosis, where is the nuclear debris? Where are the neutrophils? Okay, and here if you go closer, you see there is something in its center which has a morphology which is quite distinct. I think I am at the max. So what someone was saying, yes, this is something from outside. This look like hyphae and they are in the center, but it is inducing a very strong, what is it called? Splendor Hippoly phenomena. Okay, so wherever you see that, you see this. And there's so much so that what you described as geographical necrosis here is because of that, and the tissue has cracked here. Okay, and you have multinucleate giant cells somewhere to tell you that it has induced a reaction. But the clue to the extraneous object here being the fungus are the eosinophils. The tissue is loaded with eosinophils. See, sheets of eosinophils. So you need to answer why those eosinophils. Yes, you thought of eosinophilic, what is it called? Vasculitis. Okay. But these are not blood vessels. These are not. But you may say I may be wrong. But now I'll show you something more on the microscope. Okay. You will love it. Okay. I'm showing a PA stain. This is the PA stain. Can you see this slide?
Yes.
You can see the image from a microscope. Is it visible, Ankita?
No.
Yes, ma'am.
Yes, ma'am.
Can you see it?
Yeah.
Yes, ma'am.
Yeah. You see that there is a structure in the center of this splendor Hippoly. These are the hyphae. Okay. But we can't go more into it because it has been, it is masked by the splendor Hippoly. This is one such lesion of a fungal infection where you see the maximum amount of splendor Hippoly, which one would easily get confused with fibrin or fibrinoid necrosis of the blood vessels. So each one of them, if you look carefully, they have a hypha in the center. Okay. Now I'll take you to the presenting. Okay. So coming back to diagnosis, now is my PPT shared with you?
No, madam.
Can you see my PPT?
No,
No.
ma'am, not yet.
The diagnosis in this case were many. Started with allergic nasal polyp, granuloma, rhinosclerosis, when not many non-neoplastic, someone said granulomatous rhinitis, TB, IgG4, but I'm sure they have not picked up these fungal colonies which are so striking. Someone thought of a vaginous, I will let you know why. And invasive fungal sinusitis, I think, is more appropriate if you can't really say what that fungus is, but it's definitely not crypto. I hope you agree with that. Can that be blastomycosis? The morphology is different. I think you should look at the history. Someone said basidiobolus. Basidiobolus, I'm sure it's a type of zygomycosis. Maybe it is so. Someone thought of a lymphoma, but we didn't have any atypical cells. It looked like a very polymorphous infiltrate with lots of eosinophils, but the fungus is very striking. And someone said, yes, there is a lymphoma in addition to a fungus. So, and then angiofibroma. Okay, so these were the diagnoses offered. But what I wanted to show is that these small abscesses there tells you that maybe there is something more to it. So this was a necrotizing granulomatous infection with fungal hyphae, diagnostic of zygomycosis. And how do we type it? Is because you have the types. Is it mucorales? Or if you say mucorales, it has to be more likely, more often is mucor. But did you think it was mucormycosis, Sankita?
No, ma'am.
In mucor, you would see filaments. You don't
Filaments.
see that much of
Yes,
splendor
ma'am. Yes,
hypoli,
ma'am.
right? They are distinct, and you can really see the stem of the hyphae, which are, how do you describe the
Non-septate.
hyphae in mucor?
Non-septate, ma'am.
Right.
Non-septate.
Yeah, all those things you can really appreciate. But here, with great difficulty, you can pick up the fungus, right? You pick up the more so the splendor hypoli than really you see the hyphae. So that is what was misguiding for you to commit this as fibrinoid necrosis or vasculitis. So can this be then entophthalosis? So whether it is basidiobolus, this is more likely basidiobolomycosis, because and the treatment between mucor and this entity is very important because both could be invasive. Mucor has poor prognosis and you have vascular invasion. You know how patients with mucor deal with. We have seen them during the COVID time. Whereas basidiobolus, unlikely, they have a much better prognosis. Though they are, you can see that they're close to blood vessels. You do not see angioinvasion, even though they are in the head and neck region. And interestingly, they are treated with oral potassium iodide. There is a certain dose that needs to be given, and the patient does very well. Apart from whatever excision is done for a diagnosis, I think if he's treated with potassium iodide, he'll do very well. Unlike mucor, where you have to give systemic antifungal. So your diagnosis on histopathology and subsequent culturing with the microbiology department would help in getting the right diagnosis in this patient. So the diagnosis here in this case was basidiobolo-mycosis, which is a type of zygomycetes. And it is pretty common in the head and neck. It can occur anywhere in the body and the lesion may go on for years. The very fact that it can go for years, if you take the history in this case, it's been there for a long time. So if it was your vasculitis, fibrinoid necrosis, is unlikely that patient would be doing so well for so many years. Okay, I know I have misplaced the silver stain. Otherwise, it's beautifully seen. Is it somewhere there? I was wondering. If I get it now, I'll show you in my next slide. Okay, any doubts, Ankita? Nagaraju, you picked it up well, good, very nice. And same so with who? I think Harshita, I think in me. It's good. Thank you. We go to the next slide. That is case number 6. This would be done by Nagaraj. Yeah, over to you.
Yeah. Everyone able to see my screen?
Yes, please.
Good evening, everyone. Myself, Dr. Vajja Nagaraju, second year postgraduate, Department of Pathology from Sri Devaraja Medical College, Kolar. I will be discussing about case number 6. The history given for me was a resected colonic specimen from a 10 years old male. And this is the scanner view showing the mucosal lining, showing the rectum and the colon and followed by the rectum. And 1 second. This is see my cursor. This is the colonic mucosa and the followed by transitional zone. And here this is the area of the rectal biopsy, rectum followed by rectum. And this is the area showing the smooth skeletal muscle. We will see the anal canal also. And in the colonic mucosa is showing the mucosa, submucosa, and muscularis propria in the colon. And this picture is showing the rectal epithelium, showing the stratified squamous epithelium. And this is the area of transition zone from the colon to the rectum following. This is the second one is showing the higher magnification of the stratified squamous epithelium of the rectal region. And this is the picture of the colon showing the mucosa, submucosa, and muscularis propria. It is the arrow showing the loss of the submucosa lining. Here the muscularis propria is arborizing into the mucosal lining. Here we don't find anything submucosa. Loss of the submucosa was seen. And this is the picture of higher magnification showing the muscularis propria hypertrophied and arborizing into the mucosal lining. And this is the picture showing the caseating granulomas. And in the higher magnification is showing the caseating granulomas with central necrosis. And this is the arrow showing the skeletal muscle fiber. That's why I'm thinking of the anal sphincter. And in this one, this picture is showing the multinucleated giant cell in the for 10x view. In the 40x view is showing the, this is the picture showing the multinucleated giant cell in the form of foreign body giant cells. And this is the Langerhans giant cells will be seen in the necrotic area. And this is the 40x view in the submucosa, which are below the mucosa. It's showing the hypertrophy of nerve bundles in the submucosa and also loss of the ganglion cells in the submucosal lining. But in the 40x view in the muscularis propria is showing the ganglion cells. These are the arrows showing the ganglion cells in the muscularis propria. And also the hypertrophy of the nerve bundles was seen in the muscularis propria. That's the thickening of the nerve bundles is seen in the muscularis propria. Histopathological description. Coming to this description, section study from the resected colon tissue shows mucosa, submucosa, and muscularis propria. Mucosa is lined by simple columnar epithelium with colonic glands. At places, loss of submucosa is noted, and muscularis propria is thickened and with arborizing into the mucosa. Also seen are areas of stratified squamous epithelium and skeletal muscle bundles were seen. And also caseating granulomas with central necrosis having multinucleated giant cells in the form of foreign body giant cells and Langerhans type giant cells also seen below the muscularis propria. Also seen are the inflammatory cells infiltrate in the form of lymphocytes in the mucosa and submucosa. Mucosa. my DDs will be on the basis of the findings in the mucosa and submucosa, muscular propria, followed by the rectal and anal canal. Thus, I'm thinking of Hirschsprung disease with granulomatous colitis, first DD, and next will be the pyogeagous polyp with granulomatous colitis. Why I thought the Hirschsprung disease with granulomatous colitis? These are the points favoring for my diagnosis. First one is mostly present in males, 80%, and it will be present in the neonates and infants. In the adults also, it will be presentable. Involving gene will be RET and EDNRP gene, and the absence of the ganglion cells in the submucosa, and so in 50% of cases, ganglion cells will be seen in the muscularis propria also. The basically hypertrophy of the muscularis propria and the large nerve bundles was seen in the constricted part above the lesion will be seen the hypertrophy of the muscularis propria along with hypertrophy of the nerve trunks also seen. Involves a large bowel with rectum and anal canal. And to confirm the Hirschsprung disease with Hirschsprung disease, we had to do the acetylcholinesterase. It will tell the positive for the highly thickened nerves will be seen in the mucosa. And also calretinine will tell the loss of the calretinine expression in the it will be seen in the Hirschsprung disease. Why I thought pyogeagous polyp with granulomatous colitis? Here the most commonly it will involve the males in mid-20s and gene will be LKB1 gene. Here the muscularis propria arborizing into the mucosal lining. Where there is a loss of submucosal lining and the muscularis propria is arborizing into the mucosal lining. But the mucosal glands, there is no cellular atypia, and these are arranged in disorganization of the glands was seen in the scanner view and also in the high power. My final diagnosis in the points favored, I'll go for the Hirschsprung disease with granulomatous colitis, and further I'll go with ISC, that's the acetylcholinesterase, and along with calretinine expression. That's
Yes, Nagraj, that's very good description. Yes, you have went in detail, but I want to know what the others feel about.
okay.
Yeah. Can someone add on anything? Aishwarya, Harshita, Gina, come on. You want to add on to whatever Nagraju has described? He said there is Hirschsprung's disease, but he showed us ganglion cells, and there is granulomatous colitis. Now, my questions to you all: where is the granuloma situated?
It's near to the anal canal, where the skeletal muscle was there. There are the granulomas below the muscularis propria is there. It's not in the above muscularis propria.
Okay. If you stop sharing, then I can show you on morphal the orientation of the biopsy. Would you mind, Nagraju, stop sharing your slide, please?
Yes, done, ma'am.
Yeah. A quick look onto the slide. It's a big section from the resected specimen in a 10-year-old. That's how we had said. Yes. You know what? You have the colonic mucosa here. You can see my pointer?
Yes, ma'am.
Yes. Okay. So as we see, this is the colonic mucosa with the submucosa, and it is coming down here. And what do you see here? This famous epithelium.
Epithelium.
Exactly. You are right. But you know why? Probably one more step that I need to say is that if I say this is from anywhere else that you can have colon and have just abutting on the skin, just think over, Nagraju, whoever had intestinal obstruction, acute, and they do something, what is it called? In immediate surgery, they had to be treated, they taken wheeled into the OT, and what do?
Exploratory laparotomy.
They do a laparotomy, and if they find there is an obstruction somewhere, they would bring out the colon, that particular segment which is normal, to the abdominal skin.
Yes.
Make an opening, which we call it as stoma. Okay. So maybe I could have told you here, this child had a perforation when the child was 7 years old. and he's from the North Karnataka. So they did a surgery at 7 years. We do not know what happened. And this is so-called from the stoma. So that is why you find colon against the skin. But it still doesn't change your much description, except that instead of anal, this is going to be skin. So to say it is skin, do we have any other elements? Do we have dermal appendages?
No, I
I
haven't
think
seen
there
any
is some
set
hair
gland
follicle.
follicles.
Yeah. Hair follicle. Yeah. I think we concentrated more on this part of the tissue than on the stoma. Now, if you look at this magnification, what is very striking to you is this part which is abnormal, right?
Yes, ma'am. Down part.
Okay, so if you go closer, here you have something which is curvilinear. What do you call this? You agree that, Nagraju, that this is necrosis?
Yes, madam.
Why necrosis?
Because acellular material was cascading granulomas.
Acellular, eosinophilic, with nuclear debris.
Yes, ma'am.
Okay, and it is palisaded by what?
Epithelioid.
Epithelioid cells. Wonderful. And you have what?
Multinucleated giant cells in the
Giant cells.
foreign body
But
giant
looking
cells.
at the shape it is now. Now Ankita should tell me, aren't you reminded that this is a
Fibrinoid.
medium-sized blood vessel in the muscle wall? There is one more here. Look at this. There is lamination by the side. It looks like it's a blood vessel.
Yes, ma'am.
Here is a blood vessel which is not involved. See, and they are in the plane of the meningeal plexus. That is where normally blood vessels are seen. They come in from the serosa and in here, right? So they are in the location between the segment, that is inner and outer muscle layer. Now, if you look, as he rightly pointed out, Nagraju, yes, there is a granuloma sitting in the serosa, so-called, I'm not sure, sir, but there is skeletal muscle. This skeletal muscle is abdominal wall muscle.
Okay, after the stoma.
Okay, so it is not the anal. So, and here you have multiple small granulomas. But what concerned me was this, which was in the shape of these blood vessels showing a granulomatous inflammation palisaded by epithelioid cells. And in addition, you have giant cells here. So I was very worried this 10-year-old is having a large vessel vasculitis. Do you agree, Ankita? Nagraj, what do you say?
Vasculitis, I don't think, madam.
What do you mean by granulomatous colitis?
Like
Where
it will
should the
be
granulomas be in granulomatous colitis?
most commonly
You find
suspecting
them
of
in the outside the muscle layer. Why aren't they here in the mucosa? In the submucosa? Not even here where the skin is.
Yes,
It is little deeper down. Okay?
yes, ma'am.
Okay, that's a point we'll go and see further. And as you described, there are giant cells here. Giant cells, they are ganglion cells, light in the meningeal plexus, which is normal. But if you come closer to the surface of the stoma, as you had pointed out, the nerve bundles are hypertrophic. Right?
Yes, ma'am.
They are very thick. You showed, they were like rope. Where did they go now? Here they are. This is one location where you found the nerves which are like rope, so thick, right?
Yes.
But at the same time, you have ganglion cells by the side.
Mm.
So when you find ganglion cells, can this be Hirschsprung's?
In the near to the rect, in the A ganglion cells is a prominent feature, madam, but ganglion cells will be seen in the normal segments when they have taken the lesion above the obstruction.
Okay. So let's come to that part. But I'm more worried about this. I'm worried whether the medium-sized blood vessel there is vasculitis. You know, why on earth? And that is not one site. There is one more. So you find there are two types of granuloma. One this type and the other one which is of this type, which is on the serosa. Okay. If I go closer, you have nice giant cells. Yeah. See, lot of them scattered all over. Okay. See, they're all scattered. So they don't seem to be, they seem to be looking around for something. Anyway, I'll just show you on the microscope. I'm sure which you will enjoy. Okay. So this is a PAR stain. Okay. And if you look at this, I don't see anything, the vessel wall. So I was wrong.
This was a granuloma,
right?
With necrotic material.
I don't see the vessel wall. I see only the necrotic stuff in the center.
Yes, ma'am.
So it is not vasculitis. Then what is it if it's giving rise to so much of necrosis?
Infective etiology, tuberculosis.
Tuberculosis. But why coming from outside? Okay. So let us see, we'll handle these granulomas. I think we need to do that. I'm trying to do I'm going to polarize. Oh, it's not coming in. Can you see something here which is polarizing? I think the light is not good enough
Yes, ma'am.
for projection. Should take a picture. I think.
Mm.
Just a minute. Can you see something polarizing here? It's bifringent
It's a
within
crystal
the
like some
necrotic area, but I'm sure it's very light, but it is.
some white color it looking one.
You see, there's lots of stuff in this place. Oh, it's not projecting well. Just a moment. It should have come on. But they're all foreign body. You know, this child underwent surgery, right? So the foreign body, the suture material has given rise to these granulomata.
Granulomata formation.
It's not projecting, in spite of the maximum light. It's not coming. I'm sorry, it's not projecting. Maybe I'll post this. So these were the possibilities given. Is it shared? Sorry.
Yes, ma'am.
Yeah.
Yes, ma'am.
So actually it turned out to be that it was a case of foreign body granulomata. Is it not moving? Yeah. So it was a colostomy site showing necrotizing foreign body granulomata in the region of the anastomotic stoma involving the wall of the colon. Now the hypertrophic nerve bundles that were there, yes. When you have both hypertrophic and ganglion cell, most likely that the stoma was in the transition zone. Yes, this was a case of Hirschsprungs, treated perfectly normal, except that they were closing the stoma and we were perplexed by these large necrotizing granulomata in the region of the mindrick, which mimic that of medium-sized vessels, but which is not, we proved that it is not fibrinoid necrosis. It was a foreign body which had induced so much of necrosis. The baby was very fine. So when I said, oh, can this be? And they said, baby is very fine, so unlikely. So the baby has gone home and is doing well. So this brings to the end of the case 6. We have the last slide, which was not done. I think we go back to case number 3, Dr. Gina. That was nice, Dr. Nagaraju. Sorry, my polarizer didn't, the light was not good enough to be projected. Maybe I'll send the pictures across for you to get convinced that it is a foreign body. I didn't figure out that it would be a problem because I can see it so well and it's not seen on this system. I'm sorry about that.
Okay.
That gave the answer away, just polarization and nothing else.
Okay. Thank you.
Okay, so over to Gina, case number 3. Gina, are you there?
Yes, ma'am. Yes, ma'am.
Oh, yeah. Can you share your screen?
My case was case number 3, and I'm Gina, KMC Manipat. So the history given to me was TURBT specimen, which was sent for histopathology studies from a 57-year-old male. So there were multiple bits, which was showing some areas showing edematous areas, some had adipocytes, some had tissue artifacts as well. And in one tissue, there were some preserved urothelium, and on higher power, it was showing hyperplastic urothelial cells and had dense inflammatory infiltrates. And there were some areas showing preserved urothelium, but it was thinned out. And on higher power, it was showing some atypia. But because of the inflammation, it's most likely to be a reactive change. And there were areas of fibrosis and loosely myxoid stroma. Then there was this area which was showing giant cells, Langerhans giant cells, and foreign body giant cells as well. And in one of the giant cell, I found this, and there were two giant cells which was I was not sure of. I suspected it was fungal hyphae or something. And there was granulomas, and in one area there were cystically dilated glands, which was lined by stretch out transitional epithelium. And on my description, I given it as the section shows focally preserved hyperplastic urothelium with partial thinning and is separated from the lamina in some areas, showing reactive atypia, overlying a loose fibrocollagenous stroma showing dense inflammatory infiltrates composed of lymphocytes, plasma cells, eosinophils, and with granulomas with giant cells and foreign body cells showing fungal elements, surrounded by patchy lymphoid aggregates, and numerous dilated vessels were also noted, and a focus showing dilated glands lined by flattened transitional epithelium, and no atypia was noted. So I given the impression as granulomatous cystitis with cystitis cystica, and the I would like to get a history of a previous transurethral resection biopsy, or is he a known case of urothelial cancer or CIS, and his immune status. And my differential diagnosis will include granulomatous reaction, which is non-specific due to the BCG installation, which can be causing this granulomas, or it can be seen in a transurethral resection, and granulomas with a caseating type necrosis. Obviously, we have to rule out TB as well. So I would like to ask for special stain, sudden stain, and pass to roll out that fungal hyphae. Thank you.
Yes, Gina. Thank you. I think you did a very good job. You described all the fields and shown the relevant areas. Is there anything more that anybody wants to add on to whatever she has described? Do you all agree? Nataraju, do you want to add on anything?
There is a spindle cells is there in between myofibrillary
Okay.
areas.
So what do you think those spindle cells are doing? Could they be myofibroblasts?
Yes, ma'am. I thought the
You know, she showed some areas of fibrosis. So is it going to fibrosis? No. So you have a bladder wall which is showing areas of ulceration. You have multifocal small granulometum, right? And there is some amount of fibrosis, dense inflammation. I'm sure the patient must be very symptomatic with that kind of acute or chronic inflammation. Do you all agree?
Yes, ma'am.
Yes, Aishwarya? Yes? Yeah. Now, so I'll just try to show a few things to you. Can you see my slide? Yeah. Go back now. Just a minute. Page number 3. Okay. So the findings, as she had described, wherever the urothelium was seen, that was normal and there was no dysplasia. You know, this slide came up as a for a review.
Okay.
So as you know, they deposit the slide and the block and they go away. And when you say this is what you find, and that is when you don't know much story, you are look at, and as usual, with whatever that she has described so far with granulomata, we were left with only one thing, that there was a lot of cautery artifacts in addition to whatever was happening, and there was multinucleate giant cells scattered. There are few granulomas which were no necrosis. So the diagnosis that came up in the group is granulomatous cystitis, xanthogranulomatous. Someone thought of nephrogenic adenoma, but there are no tubules, there are no lining epithelium, so I don't know how someone thought of a nephrogenic. Emphysematous cystitis, I think they must have mistaken to the cautery effect where the, you have those artifactual changes which must have got confused with so-called emphysematous, but it is not. Malacoplakia, sorry, there's an error, but there were no inclusions, but were the sheets of macrophages, which is very typical, which we didn't find. Inflammatory fibroblastic tumor, I'm not sure, but I thought all these with doubts. Yes, we someone thought of schistosomiasis. Maybe they looked at that inclusion up there in one of the giant cell, but didn't have a distinct morphology of a schistosome. So it's a very large parasitic. The structure that you would say, but this was very small. Eosinophilic granulomatous. Yes, there were eosinophils, but these are all very descriptive. But do we have a specific cause for this? Was our findings. Someone thought of an angiomyolipoma, which I don't think it is, because we didn't have any one of those elements. So what do we do next is ZM as needs to be done. Yes, it was negative pass. Yes, it ruled out vasculitis, which I always think, sometimes when not, your eye should go for blood vessels, because that's one which you need to exclude in all your biopsies. Good too, even though the clinical scenario may not be given to you. But I always think, phone a friend. That's when I called to the surgeon and said, why have you sent this biopsy? Don't find anything other than the granulomata. What are you looking for in this biopsy? Can you tell me more about the patient? So much so, he came up to say that, yes, this patient was treated, was diagnosed as invasive papillary urothelial carcinoma of the bladder, and that had lot of carcinoma in situ changes as well. And 6 weeks prior, the patient had undergone BCG immunotherapy, so it was instilled into the bladder as one of the treatment protocols. And post thereafter, they have done a cystoscopy and they saw a small growth. So he has biopsied that so-called small growth, which was nothing but what we have seen so far. So this looks like probably it is a post BCG, as was rightly thought of by Gina. Yes, it is a granuloma seen after intravesical BCG. It tells you that more the immune response, better for the patient. And this article talks about the prognostic value, good to read, and managing the adverse events, so much so it can become systemic, and how do you manage these patients? But they seem to settle down without much treatment and they wouldn't be treated for tuberculosis or anything. So you must keep a watch on this, have a good follow-up, and make sure that, and the follow-ups are purely for onco purposes. So these are nice, good articles which, to tell you that whenever you see a granuloma, wherever they be, in each organ, it's a different story. So it doesn't mean if you see granulomatous, it becomes tuberculosis. So all that glitters is really not gold. Okay. So we have granulomatous you have seen in various organs, various situations. Some are post-treatment, some are post. They have a reason why they are there, and how do we pick them up? How do we interact with the surgeon? How do we give a diagnosis and word it in your comment section and follow up? And the most important, learn to phone a friend. So that gives half your diagnosis. And the other half, I'm sure, is the clinical scenario. So all put together with good microscopy, morphology, and correlation, I think you will make a very appropriate diagnosis, and which could be timely. So the final diagnosis went as TURBT specimen following intravesical BCG therapy, and there were no demonstrable acid for speciali in this case, and there was no evidence of dysplasia by malignancy. So the patient, as of now, yesterday had called up, he's doing very fine, and he is off all medications. He's just on regular follow-up. So I think that brings to the end of the 6 cases discussion. So is there anything that you want me to answer for the cases? Or can Shruti, Dr. Shruti, please take over?
Yes, ma'am. Thank you, ma'am. Thank you so much for that delightful presentation. I think you've added an entirely new dimension towards approaching granulomas. I don't think we will ever look at a granuloma with a linear vision anymore. Thank you. And I just want to say, all the postgraduates, you've done a wonderful job, but we need to pick someone. So I would like to call upon the judges, Dr. K.V. Santosh and Dr. Ramaswamy AS. Dr. K.V. Santosh is a senior consultant pathologist at RV Metropolis, Bangalore. And Dr. Ramaswamy AS is professor and HOD, PES Institute of Medical Sciences. So I would like to hand over the platform to them both. Please kind of give your comments and announce the winners.
Thank you, Dr. Shruti. If I may go first, Dr. Ramaswamy.
Yes, sir, please, sir.
Yeah. So congratulations to all the participants. I think you've done a great job, going ahead with the descriptions, wonderful descriptions, and your attempts to come to a conclusion on the diagnosis. And it was very difficult to differentiate between each of you. And I had a tough time giving, the exact points that would be ideal for all of you. And I would like to say that the top person who has got marks is away from the next 3 participants by 0.5. So that is how close it was. And overall, all of you had very good descriptions. Your differential diagnosis and the diagnosis suggested were excellent. I would suppose you could have gone a little bit more into the negative aspects in your descriptions. Many of you did not. And also a little bit further on additional investigations or comments that could have been a little better, I felt. And the answers to questions posed by ma'am were all well answered. And all of you adhered to your time limits. Excellent. So from the points that I allotted to all of you, I find that Dr. Arijita Banik has scored the maximum. And she is followed by 3 others, Dr. Aishwarya MS, Dr. Gina Thomas, and Dr. Vajra Nagaraj. All of them have scored 0.5 less than Dr. Arijita Banik. So congratulations to all of you, not just Arijita, to others and everyone who participated. The difference has been 0.5 to 1. So that's how close you all have done. Thank you all. And thank you, Dr. Shruti. Thank you, Ma'am Usha Kini, ma'am, for inviting me over. And thank you, Aditya. Thank you, Team KCIAPM. Over to you, Ramasamy.
Yes,
Yeah.
we're looking
Good evening,
forward to it.
everybody, and good evening, Team KCIAPM, and thank you all for giving me an opportunity to join this session online. And as Santosh sir has rightly pointed out, and as Usha Kini ma'am had at the outset, introduced to the session, what anybody starts looking at the slides is not the diagnosis, because the art of communication is the forte of a pathologist, and how well we communicate both to the patient and to the clinician who is involved, and we guide them further and we handhold them literally many times to lead to a right diagnosis. So in this slide seminar, as we were looking for, it was not the the diagnosis which we were interested in. It was the approach, how the students were, and all of you have done extremely well, and very beautifully held on to your timings. In the limited time of 4 minutes, you were able to describe and offer your differentials, and some of you could even suggest the additional comments and investigations, as madam was suggesting at the opening of the session. And I totally concur with sir, because it was a very tough call to differentiate one from the other. And I too stand by Dr. Santosh's assessment that Dr. Arijita from JJMMC, she has done a wonderful job, and she topped the scoring in my charts too. And so congratulations, Dr. Arijita, and congratulations to all other participants, Dr. Aishwarya and Dr. Harshita, Dr. Lina, Kita, and Dr. Nagraj too, for your active participation in the session. And thank you, Usha Kini ma'am, for giving us this chance, ma'am.
Absolutely. I think it was marvelous, seeing this young pathologists, budding pathologists give their diagnosis. I hope it was your own and not taken, from the consensus of the department. But nevertheless, you answered all the queries, so you knew and you're learning. So that is perfectly all right that you get to have other people teach you. But as they say that the first 5 minutes, no, not even 5, the first 3 minutes of you putting the slide under the microscope without any history is what is going to take forward. That shows you how good you are, unbiased, that you can make a diagnosis. So you just need to know where the biopsy is from, how old is the patient, and the age of it, and if these three things are known, and you put the slide under the microscope and you make a certain diagnosis, and I think the rest of it is you correlate. Then you know where one jigsaw puzzle is missing, and yes, that is where you need to push into, and that is what makes it complete. So, but I think you should train yourself to look for the first 2 minutes of you peeping into the slide, which is actually that you are examining the patient as a pathologist, because behind every slide there is this patient. Okay, I hope you enjoy pathology, and and it is and it should take you forward, though you are just probably 2 years in pathology. I think you're all in second years, and if I think Nagraj is in the third year, but nevertheless, you have a long way to go. But I hope you enjoy the journey and enjoy every moment of it. Thank you so much from my end, and thank you very much to KCIAPM to have allowed me to given this chance to put across these cases, which though simple, they look like granulomatous, but I thought the workup is more important, and that's the highlight of the session. So thank you very much, Dr. Aditya, as well as Dr. Shruti, to have held on to the the platform and have guided me all through. Thank you, Dr. K.V. Santosh and Dr. Ramaswamy, to have been through these last 2.5 hours. I'm sorry I kept you waiting. We have exceeded by half an hour. Thank you. Thanks so much.
Thank you so much, ma'am.
Thank you, ma'am. Dr. Aditya here. I would like to thank you, Usha Kini, ma'am, for enriching our platform with such wonderful case presentations and case discussions. I'd like to thank the judges, Dr. Santosh sir and Dr. Ramaswamy sir, for judging our participants and understanding that all of them had done an excellent job here. I would also like to thank Dr. Shruti Chandra, ma'am, from KIMS Bangalore, for moderating the session exceedingly well. Thank you. Please do join us for the next webinar that we have by Dr. Siddhartha Gupta sir next Saturday at 6:30 p.m. on inflammatory bowel disease biopsies. Thank you all. With that, we'll close the session. Thanks for joining us today.
Thank you so much.
Thank you.
Have a good evening and good night. Thank you.
Thank you, madam.
Thank you.